Good morning, everyone. I wanted to take this opportunity to talk about a disease that's near and dear to my heart, Epidermolysis bullosa. I've had the privilege to work with children with EB for the past few years. While this is a very rare disease, you may have the opportunity to work with children with EB at least once in your career. Therefore, I wanted to go over the care guidelines that we have here at CHOC so that we're all familiar with what to expect if a child with EB comes in. Briefly, I wanted to give a shout out to Camp Wonder. I have been fortunate to work as counselor for Camp Wonder for the past few years, and they do a wonderful job providing children with life-altering skin diseases a week of fun and happiness, often when these children's lives are overwhelmingly fraught with pain and stigma. I wanted to speak specifically about EB today, one, because CHOC recently revised their care guidelines for fragile skin, and because we are all greatly saddened by the passing of one of our campers this past week. While this is a very short presentation, I wanted to dedicate this talk to Deeb as well as his family. As a brief medical school style refresher about EB, there are 4 forms of EB, all characterized by at least skin fragility and sloughing, sometimes from even the most minor of contact. They differ by which proteins in the skin are defective or mutated. EB simplex is the most common form of EB, and it's due to mutations in keratin, typically keratin 5 and 14 found in the epidermis. We also have junctional EB, which involves hemidesmosomal proteins, most commonly laminin. There's also dystrophic EB, which will be the focus of my talk, which involves mutations in type 7 collagen found below the lamina densa. And finally, we have Kindler syndrome, which involves mutations in the focal adhesion protein kindlin. The dystrophic form of EB are some of the most severe forms of this disease and are characterized by generalized blistering that can also involve mucous membranes and occasionally the upper 1/3 of the esophagus. With severe forms of dystrophic EB, internal organs are often involved. You will also see scarring, nail changes, and milia formation. Complications include pseudosyndactyly, as seen by this picture. This is also known as mitten deformity, and is caused by repeated cycles of healing and injury around the fingers and toes. You may see children coming in with dressings between their fingers and toes to prevent this. Other complications include esophageal and anal strictures from repeated trauma, dystrophic teeth caused by decreased mouth and tongue mobility causing extensive caries, reduced food intake, nutritional deficiencies, anemia of chronic disease, and osteopenia due to reduced mobility. A significant complication of EB in general are squamous cell carcinoma, which are among the leading causes of death in EB. Oftentimes, these children will die in early adulthood due to infections or severe malnutrition. Here at CHOC, if you have a child who comes in with EB, there is an order set that includes the following. Generally, these children will need to be kept in contact isolation as they are prone to complications from infection. Oftentimes, in older children, you will see that they already have G-tubes in place, but in infants, oral feeds should be encouraged. ID bands should be placed at the bedside and not on the wrist to avoid injury. For this reason, the bed should also be kept flat to prevent shear, and generally, the least invasive measures should be used for monitoring and interventions. If you have a child that comes in with EB, you will need to consult wound care and notify a clinical nurse specialist immediately. Anytime you interact with the child, it's a good idea to apply a thin coat of Aquaphor on gloves or medical equipment prior to contact to avoid injury from friction. And generally, adhesives should be avoided in these children. For wound care or to secure an IV, it's advised to use Mepitac or a stockinette, and generally it will be a good idea to talk to the caretaker or parents of the child, as they will often have individualized ways of managing wounds in EB. Children with EB oftentimes require extensive pain management, so pain control will depend on what the child is already prescribed. Here are some other tips that I found that are not specifically laid out in the guidelines. Generally, you really want to be gentle with these children, so using things like soft catheters for suctioning is a good tip. Also, turning clothes inside out to prevent erosion from the seams, and using paraffin to avoid erosions from the diaper edges may be appropriate in certain situations. Like I said earlier, PO intake is preferred for infants, but for whatever reason, an NG tube can be used for feeds for up to 6 weeks, and you should think about placing a G tube in children with failure to thrive. To avoid skin infection, it's preferred to use a bleach bath or topical chlorhexidine, benzalkonium chloride, or silver sulfadiazine. Mupirocin should be used sparingly in order to avoid microbial resistance.